Welcome to Bamata Ginonendwa. This podcast is produced by the Communications Department at the Anishinaabe Nation. We will be focusing on the issues and initiatives in Anishinaabe Nation territory. I'm your host, Lisa Abel. Anishinaabe First Nations have been advocating for years for increased control over our health and wellness. Historically, the health system and structures in place have failed to meet the health needs of our people and communities. Our Anishinaabe Nation Health Transformation Team has been meeting with First Nations leadership and our healthcare community to talk about a vision for a system that's accountable to us. Imagine Anishinaabe healthcare that's controlled by our First Nations, where we make the decisions about how money is spent and what kind of health services and programming are offered. And that's not all. Health transformation has the potential to put us in charge of non-insured health benefits and medical transportation for our communities. It could also bring in health business opportunities like our own pharmacies and medical labs. Does this sound too good to be true? The British Columbia First Nations Health Authority has been administering their own health programs and services for their First Nation communities since 2013. Other First Nations-led institutions and organizations in Manitoba, Nova Scotia, Ontario, and Quebec are also working on health transformation projects. In this episode, Phyllis Williams and John Cherabny update us on the work of the Health Transformation Team and what they have been hearing in conversation with Anishinaabe Nation communities. I'm here today with Phyllis Williams from Curve Lake First Nation, who is now a health advocate for the community and I guess the Anishinaabe Nation at large, and John Cherabny, a fiscal analyst with the Anishinaabe Health Transformation Initiative. So thank you for taking part in this podcast.
Thank you.
Thank you for having us.
Miigwech. So let's start, if you can, both of you in turn, if you can tell us about yourselves and your role in this project.
I've had a strong background in health and social services over the years. I'd say 35 years plus. It's a passion for me to work in health. And in fact, I've worked for the Anishinaabe Nation in the past. I was the health director here. And at that time, we formed a health commission. So we were sort of on the way to where we're at now. And I feel that groundwork and that background really gives a basis for the Anishinaabe Nation to move forward and take up the lead in health transformation. So that is my hope, that is my wish, that is my passion. And so to date, I've been working with First Nations at the local level. I've worked in the urban setting with the Indigenous Friendship Centers and Anishinaabe Health downtown Toronto. So I was deliberate in doing that to get a basis of life in the city for Indigenous people. So it formed a good mix for me and a better understanding of the challenges and issues that were present and still are present. So that's why I feel I still have work to do. And even though I've been chief in the past and council member, that has always been at the forefront for me to do that kind of work. So I feel very compelled and very committed to do that kind of work for our people.
Miigwech for continuing to give of yourself and share your knowledge and expertise in this area, Phyllis.
Yeah, miigwech.
Miigwech. And John, let us know a bit about yourself and your role in Anishinaabe Health Transformation.
Okay, well, thank you for the opportunity to talk about health transformation and what it can mean for the 39 Anishinaabe communities. I have been part of the health transformation team as a fiscal analyst for several years now, and as a CPA, a professional accountant. I have been working in finance for over 40 years. Many of those years has been with First Nations organizations right across Canada. My work before joining the Anishinaabeg Health Transformation Team was as the treasurer of the BC First Nations Health Authority. As you may know, in 2012, the 200 BC First Nation communities had taken control of their health programs from the federal government and now run an Indigenous First Nations Health Authority. As the treasurer of that health authority, I was the fiscal representative in the negotiations of the authority's annual budget, which at that time was $500 million. And right now they have a staff of about 1,000 people. So I'm hoping that with that experience, I can assist the Anishinaabe communities to take control and reclaim their health.
Miigwech, John. So you're both bringing an interesting mix, of experiences. John, you're bringing a lot of this financial knowledge, really, I guess, like how to negotiate these kind of contracts and funding agreements. And then Phyllis, I'm understanding you're bringing, your political knowledge and knowledge of systems here in Anishinaabeg territory and knowledge on the ground of what the health systems look like, either on reserve and off reserve.
Exactly, yes.
Sounds like a good start already. I understand this health transformation process has been going on for a while, but just to start, what does health transformation, what does that mean? Why should health transformation matter to our Anishinaabe Nation citizens?
I think the basis of why should health transformation matter comes to looking at the data and the state of First Nations health. When Indigenous people suffer significant health disparities when compared to the non-Indigenous population. So there is an answer. There are communities, and those with a higher community control of their health were found to be associated with improved health incomes. So in order to get the health population better, the answer is controlling your own health and having your own health systems. And this is what health transformation is trying to do, is to create First Nations Indigenous health system. So we believe that with health transformation and with First Nations taking control over their health, that those statistics will definitely improve and the population will become healthier. And the data shows to date that with control of your health, which includes financing, which includes less bureaucracy, that the system will work if First Nations people are given the ability to reclaim their health.
When you talk about fiscal relations, right now some communities have as many as 26 contribution agreements, whether they're federal or provincial. It's such a mishmash of accountability, and that accountability should really rest with the First Nation, not with the governments. It means, for me, taking control and taking the, the work where it belongs. It should be with the First Nation to determine what their future will be and how that will be done. And because we're so challenged with conforming to agreements and the criteria within those agreements, we're limited to do the work that needs to be done. The priorities are lessened in terms of what can be funded and what can't be funded. I hate bringing the mix of funding into it, but what John is saying is the reality in the First Nation. So it's hard to work in that setting when you can't determine your own priorities. You can't build your own capacity, and you can't pursue those careers that are most needed in your community, because it needs to be culturally based, and it needs to be things like on-the-land learning, something that's very meaningful and very powerful for the First Nation member who is having those challenges. And not only to say the member themselves, but it's the family, it's the community, because it's that impactful in a First Nation.
So you're mentioning it's very important that First Nations can determine, their health priorities. So if I understand it, you're hoping that with health transformation, First Nations communities could just say, these are really the health concerns in our community, and this is where we want our funding priority to be, not based on what kind of program is made available by other levels of government.
Yes. And many times those criteria are determined year to year or within a set time frame, where in the First Nation, we don't necessarily have time frames because health is health. It continues. So we need the ability to determine our own health mechanisms, our own healing and wellness. So there is no end to our planning. It's a continuum of planning. It's not just meeting a set of criteria for a certain point of time. We need that ability of living on for the sake of that purpose. It's really hard to plan on a one-year cycle. Very, very difficult. So we need that continuum.
So how did the health transformation process start with the Anishinaabe Nation, and where are we going today with it?
The project started back in April of 2018 with the signing of the first foundational document, and it was called the Health System Transformation Relationship Document. It was a tripartite agreement that was signed by the Anishinaabe Nations, the province of Ontario, and the federal government. And the objective of that foundational document was to create a system that included sustainable funding models with new fiscal arrangements and decision-making structures that will increase First Nations authority, control, and oversight. So I think that was the key document that started the whole process back in 2018. Then later on in 2019, there was a tripartite planning and information committee that was put together, again, by the three parties. And the intent or the objective of that committee was to develop strategic direction, set priorities, and make recommendations for transforming the existing health services and program delivery models for First Nations, which would include increased First Nations control. So the mandate, the documents, or the structures to get the process going was all agreed to by the three parties. And then COVID hit. And then the engagement processes were stopped for the most part because of COVID. But during that time, a working group was formed, and we had some Zoom sessions. And with Zoom, that was pretty difficult to do, as you probably are well aware. But at least we kept the conversation going. And then after COVID, we started with working group sessions, and I think we've had about 4 of them already to this date, and well over a dozen community engagement sessions where we visited the communities. In September of last year, Grand Council Resolution 2023 directed the Health Transformation Team to develop a business case, and that's to obtain funding for the next level of enhanced community engagement with community memberships. So this would give communities and members the opportunity to provide input and direction to health transformation implementation and what an Anishinaabe Health Authority might look like. The business case was presented to FNIB, and they favorably accepted the business case, and now we're waiting to see what Budget 2024 will bring for the funding that we're requesting through this business case. So that's where we are today. We do intend to carry on with community engagements at the level that we're proceeding right now, and yeah.
Wow, so I guess you're hoping for some good news in Budget 2024.
Soon.
Ooh. So you mentioned, there's been some working groups, there's been some engagement. Like, who exactly has been involved in different stages of the process?
So up to this point, it's been mainly chief and councils that we've been visiting. We thought that we have to follow the protocol of what the authorities are in the community. So we started off with the chief and councils, and we're trying to, they're very busy. There's all kinds of things, as I'm sure Phyllis appreciates, going on at the same time. Although all these other activities are important, we're pushing the health side of it because that's important too. Hopefully we can through this podcast and through other communication efforts, we can get to all 39 communities in the next year or two. We're ready to go and talk about health transformation. Again, this whole process is community-based and nation-driven. We don't want to go to a community and say, this is what health transformation should look like. We want to get input from the communities because it's their health system, and they're the title holders, and they're the ones that are going to decide what health transformation finally is going to look like, and that the pace and timing is going to be a community decision. The health transformation team is there to facilitate that process, to provide as much information as we possibly can, to provide alternatives, to come up with models for discussion, to present the different variations that there is to health transformation.
I'll add a bit. With regard to the working groups, there's been a mix of people involved, be it the health directors or managers, CHR, NADAP workers, addictions people. And, throughout that process, they can go in and out freely as they wish. Leadership has been involved, knowledge keepers. So it's a very welcoming group. And, while we talk about leadership, it does make room for anyone who wants to be part of that.
So I guess this working group or the health transformation team has been doing engagement. So what have you been hearing so far? What's the energy like out there about this project?
It's been very, very good. The people attending the working group have been engaged. We've been trying to share with them all the information that we have. They've worked well. There's been some very good attendance. We do struggle a little bit with getting representation from each one of the 39 communities. So we're encouraging chiefs, and wherever somebody makes a presentation, we're encouraging the chiefs to make sure that they pick somebody to come to the working group sessions, because at the end of the day, it's going to improve their health. So but they've been well attended. We've had good presentations. We've had the province presenting. We had the federal government presenting. We had various physicians and doctors and people talking about programs. So it's been a very good process.
And the First Nations have also had opportunity to bring their story, what's happening in their communities, what programs and services exist, what services are the gaps, So there's a good mix, as John is saying, and certainly there's the difference of north and south, east and west, and it kind of brings that reality and knowledge to the whole working group, so that you're being inclusive at the same time.
Yeah, and some communities are large and they have pretty extensive programs, and some communities are small. And so it's interesting to watch the smaller communities looking at what the bigger communities are doing and learning from them as well. And so just by the working group process itself, there's a benefit to the communities just by them exchanging information and exchanging ideas. And you kind of see one community talking to another community during the off session, and asking, well, how do you do this, and what was your experience in doing this, or are you having trouble with Ontario about this, and you can see the conversation, and it's getting people together.
So a good amount of information sharing and kind of growth. So, what's your timeline looking like right now? Can you kind of list the number of steps then that need to happen before we're?
Sure. We've got again, it's a roadmap that we've developed, and again, it's something. Well, one thing we learned from one of our community engagements was with one of the chiefs, and we were talking about what models we've had for what a health authority might look like, and he said to us, "Well, can you share those models with us?" And we said, "Yeah, there's no problem sharing." He says, "Yeah, don't come to us with a blank page. Come to us with something, and we'll take a look at it, and we'll tell you whether you're on track or not, or what has to be changed." So we're trying as much as possible to throw as many ideas out there as we can, and sort of see what folks are kind of sticking to and what they don't like. So we've got like three governance models that we talk about during our presentations to the communities, and there's one model that everybody's kind of leaning to. Again, it's just a model; it's for discussion purposes, and so it's important to go to communities and let them have an input, and we've developed, as I was saying before, a business case where we can go into some really intensive engagement processes where we can have community meetings and where we can talk to community members to get input from the community members, how they see health. Because at the end of the day, when you look at the community programs in communities and you look at non-insured health benefits, of the 70,000 First Nations, Anishinaabe First Nations, probably 80-90% of them are going to access programs in the next year. Somebody's going to go to the dentist, somebody's going to get a prescription, somebody's going to get their eyes checked, somebody's going to see a nurse. So everybody's got an interest in health. And so we want to get as much input from communities as we can, so the organization that we build is going to be something that's representative of what the communities want.
I was looking at the literature that's available on the Health Transformation website, health-transformation.ca, and it seems like, it's a pretty large vision too. In the literature, I'm seeing that there might be the possibility of discussing, a health authority covering medical services, dental, pharmacy, labs, patient transportation, traditional medicine, and long-term care, addiction treatment, midwifery, mental health. Will health transformation, do you think, will it be really involved in that many areas? Is that really possible?
I personally believe yes. If you follow the BC model, there is no more federal health in British Columbia. The only health services is through the First Nations Health Authority and with the province. So there's only two parties really delivering health services now. I believe if you take over your health services, that you take everything over and you deliver it, and through the governance structure, communities and the health authority will decide who does what. And maybe sometimes the community will come along and say, we want to hire our own nurse, and that would be fine. Maybe some communities would come along and say, no, you provide the nursing services, and we won't bother with nursing. You provide that services, and that would be fine too. So again, it's hopefully it's going to be a system that's flexible and meets the needs of communities, and that's what it's all about. But the initial effort is to get the FNIP part, the federal government, out of the process. The provincial health services is going to be there forever. They're not going to go away. So then with a strong health authority representing hopefully 39 communities, we'll be able to be strong advocates with the province and improve the services the province provides the 39 communities if you have a strong central organization to be advocates on your behalf.
Phyllis, what do you think about what difference it would make if in our First Nations communities we really had access or control of that wide range of health services?
I think it's a beautiful vision. I think that people would adapt and be quite involved. You know, I think about the elders and the seniors who are lacking in services right now, you know, long-term care, sometimes mental health services. You know, it would be, I hate to say it this way, one-stop shopping, but it would be certainly a pivotal point central point for our nations to be able to go to those centers, I'll say, and get that ability to have their own wellness plan, because it is ownership of health, really. And that's what we need to instill into people and instill into our nations, because it is about their being, their wholeness, and their want to be on that wellness path. So it would have that enhanced servicing at a one-stop shopping place. That's what I'm feeling.
And I imagine too that it would just be amazing to have all of these services, you know, in close proximity to our communities and really reduce the need to be traveling, sometimes for some communities, really great distances to access health.
Yes, and that difference of services, you're correct. You know, north south. Like many times, I think about the northern people and their challenges to get to their services, say in Toronto or Kingston or wherever they have to go, and they're going to a strange place. They're going to unfamiliar territory. They don't have family and friends readily available for comforting or giving them any piece of having them create their own wellness path. Lots of support and encouragement is needed in that journey.
So just to add to that a little bit, in the contribution agreements that most communities have with FNIB right now for medical transportation, there's a clause in there that describes what the catchment area is and what is covered. So sometimes those catchment areas just don't make any sense. But if somebody goes outside those catchment areas, the funding doesn't get approved for that trip. If First Nations took over their health, then they can decide what their catchment area is. And if they want to make exceptions to it, well, they can go ahead and make exceptions to it. It's their decision and what makes more sense to them.
So in the future, once we have this vision of when, you know, health transformation and when a health authority really is in place, what kind of resources might we see in our communities? Would there be new buildings, like facilities constructed? Might there be more health professionals hired? You know, there'll be more programming. What would it look like on the ground?
If I can compare what we have today to what we could have in the future, it's just enormous. Our health centers are overflowing. We are so crammed and crowded, it's hard to do your work. And if we had better buildings with more space and ability to house professionals, we would have a better access to services right in the First Nation. And instead of, you know, sending our people to doctors and professionals elsewhere, we'd have the services come in. And that way you have the ability for better planning, better resourcing for sure. You have a better sense of building those partnerships that we talked about earlier. We need to think in those bases of practice.
Phyllis, you mentioned, you know, the importance of having our own healthcare professionals. Do we think that this health authority might be involved, you know, in the training or recruitment or making sure it's competitive compensation for healthcare professionals coming to work in our communities?
I mentioned career building before. We need our own doctors. We need our own health professionals. We need our own foot care people. Like, I mean, it's that basic, but yet we need to be enhancing and bringing those services to our own First Nations, but building the capacity for our own people so that they are doing the work and not someone else from a nearby city. Because it'll give that sense of healing and wellness and empowerment to the member who's seeking that resource. So I think it instills that more ownership of health to them. That's where the partnering comes in. You know, we can talk about health and social services because they sort of combine each and enhance each other, but we need to look at education and other parts of our First Nation governance so that there is that internal capacity building within. So we would have to be looking at employment and training and building that partnership internally to come up with that capacity building.
So is there anything else each of you would like to add about health transformation?
I'd like to talk a bit about the business of health. Ontario spends about $60 billion a year on health, and that's a lot of money. And they spend a lot of money on doctors and labs and dentists and all kinds of other health programs. But health is a big business. There's a lot of money in health. And so one of the branches of health transformation is to get into the business of health so we can generate revenue, and that revenue that we generate, we can take that money and put it back into the health programs. So those services that people are now not getting because of the fiscal constraints, they're able to put some more money back into the system to be able to give those programs or services to the people that are not getting them now. And the other thing is when you're looking at, Phyllis was talking about careers. I think that's also very, very important because the example that in British Columbia, when FNIB was there, FNIB had about 250 odd people working for them in the whole of the province. And so right now, the health authority has almost 1,000 people working for them. And those jobs are in communities, and those are good paying jobs. And just having good paying jobs improves the health of a community because the money comes into the community and stays in the community. And so it's, when you're looking at health and social determinants of health, having your own health system and being able to manage it and generate revenue, it just makes things better.
Phyllis, what do you think? Did you have anything you'd like to add?
I'd like to add that, that racism and health inequities are still present. I still hear the stories that people aren't treated well when they have to attend a off-territory institution. And that's such a shame in these days. We can talk all we can about reconciliation, but the reality is that we need to train the professionals that are there already, and they need to understand the culture of our people and how we need to be treated well and be respected. So I'm doing some work in that regard right now as I speak, and so we need to sort of let that be something that fills the hearts and souls of people, and those people we look to right now and in its current time with the professions that are out there that are looking after our people. I think that it's a very sobering reality, and we need to stop it. We need to regain that respect and what we expect of the people that look after us right now. But, with health transformation, that's another huge goal that we can look at, to have our people treated better in their journey to wellness.
Miigwech, for bringing that up. That is really an important factor in our care, as you mentioned. And I guess there's also work being done, not only in, the cultural competency training, but also developing, real policies, that will address racism in healthcare. Yeah, so that policy piece is important as well.
Just an offshoot from what we just talked about, we can place our people, our members into hospital boards and public health boards and those service providers, but that's only a very one by chance voice sometimes. You're just like the old saying, you're only a brown face around the table. And sometimes your voice is not heard. And I think, it's time we take over our own health once and for all.
Miigwech. John?
I couldn't agree with you more. I think it's there. It's there for the stars are aligned properly right now, like the federal government, I think, is anxious in showing health transformation works. They did it once in BC, and it hasn't happened anywhere else. There's a couple of processes going on, some in the Maritimes, some in Manitoba, but I think we're the furthest ahead as far as our engagement process is concerned, and I think it's time. It's time, and it's the government wants to do this. First Nations want to do it. The key, and I think it's a very important key, is that there's enough money at the end of the day to run the system properly. Because if there's not enough money to run it properly, why would you take a broken system and try to fix something that's broken that you don't have enough resources to fix it? So the key is to come out with that dollar amount that we think we need to run a good health system for the 39 communities.
Miigwech. And I think, I imagine that Anishinaabe Nation citizens are probably looking forward to this, and I hope that there'll be, lots of opportunities for everyone to get involved. So Phyllis Williams and John Cherubny, Miigwech, thank you for sharing your knowledge today and taking part in the podcast. Miigwech.
Thank you.
Thank you. Since our conversation, the 2024 federal budget announced $104.9 million for First Nations health transformation initiatives across Canada over 5 years, starting in 2024-2025. The Health Transformation Team continues to meet with communities, with both a Lake Huron Region engagement session and a working group meeting in the works for this summer. Miigwech to our guests, Phyllis Williams and John Cherubny, and the Health Transformation Team. For more information on health transformation, how to book an engagement session, or how to join the Health Transformation Working Group, visit health-transformation.ca. This episode includes our theme song, Brothers by Wolf Saga and Chippewa Travelers, and the track Big Drum by Don Ross. Thank you for listening to this episode of B'Madzijig Ginonindwa. Until next time, Bama Pi.